Welcome back to Med School Radio. I can't remember if I was in junior or senior high school when the song Tom Sawyer by Rush first came out. All I remember is that I used to crank it up.
This is a tasty burger.
Welcome back to Med School Radio. We are going to talk about Guillain-Barre syndrome. And we're going to talk firstly about the topic by looking at some flashcards on osmosis.org. So let's go ahead and look at all of these flashcards. There are 13. So let's get going. Guillain-Barre syndrome is caused by an autoimmune reaction that leads to demyelination in the central or peripheral nerves. Which one is it? And the answer is, of course, the peripheral nerves. Next one. Blank is the most common organism associated with Guillain-Barre syndrome. It is Campylobacter jejuni. This is the most common organism associated with Guillain-Barre. Next, Guillain-Barre syndrome is a life-threatening neuropathy involving ascending or descending paralysis. Which one is it? And it is, of course, ascending paralysis. In Guillain-Barre syndrome, the analysis of the cerebrospinal fluid shows normal or increased protein content. Which is it? And the answer is increased protein content. The underlying mechanism of blank syndrome involves an autoimmune reaction where the immune system attacks the peripheral nerves, resulting in demyelination. That's Guillain-Barre, of course. Next, the most common viral causes of Guillain-Barre syndrome are cytomegalovirus and what other virus? It's Epstein-Barr virus. The onset of manifestations of Guillain-Barre syndrome usually occur within weeks or months. That's weeks. In Guillain-Barre syndrome, the analysis of the CSF shows normal or increased white blood cell count. Normal, the white blood cell count is normal in Guillain-Barre syndrome. In Guillain-Barre syndrome, the presence of increased protein content with normal levels of white blood cells in the CSF is called what? Cytoalbuminologic dissociation. Cytoalbuminologic dissociation. This is the presence of increased protein content with normal levels of white blood cells in the CSF. In this syndrome, there is a life-threatening neuropathy involving ascending paralysis and eventual death from respiratory paralysis and cardiac arrest. And this is Guillain-Barre. The main lines of treatment of Guillain-Barre syndrome are what? Intravenous immunoglobulin and plasma exchange. Guillain-Barre syndrome is what type hypersensitivity reaction? Type 1, Type 2, Type 3, or Type 4? It is a Type 2 hypersensitivity reaction. And lastly, in Guillain-Barre syndrome, the muscle weakness is symmetric or asymmetric? The answer is symmetric. Okay, so those were the flashcards from the website. And next we're going to look at the questions. So let's get started. I've already done half of them. I'm going to try some new ones that I haven't tried yet. I have 5 left, which I haven't looked at, so let's have a look. A 35-year-old man with no significant past medical history comes to the ER because of lower extremity weakness that began 3 days ago. He notes that his legs feel heavy and that he has been stumbling. There is some mild tingling in his lower extremities and hands as well. 2 weeks ago he saw his primary physician for gastroenteritis, but the symptoms resolved without intervention. Physical examination shows diminished sensation in the bilateral hands and feet with generalized weakness to all 4 extremities that is more pronounced distally. Patellar and ankle reflexes are absent bilaterally. A lumbar puncture shows increased CSF protein with a normal cell count. Nerve conduction studies show conduction blocks and conduction delays. Which of the following interventions is the most appropriate treatment? Is it A, intravenous acyclovir, B, intravenous ceftriaxone, C, intravenous immunoglobulin, D, oral azithromycin, or E, oral corticosteroids? And the answer is C, intravenous immunoglobulin. The major takeaway here is that Guillain-Barre syndrome is an autoimmune disease that causes peripheral demyelination. Management involves plasmapheresis or administration of intravenous immunoglobulin. So for this one, I'm going to read the main explanation, and for the other questions I'll just skip over. So GBS is an acute demyelinating polyneuropathy affecting the peripheral nervous system characterized by symmetric ascending paralysis, classically beginning in the hands and feet and ascending to the trunk. Additionally, some subtypes may cause sensory changes or autonomic dysfunction. GBS is usually triggered by a preceding infection about 2 weeks prior to presentation, with Campylobacter jejuni being the most well-described antecedent. The most common type of GBS is acute inflammatory demyelinating polyneuropathy, or AIDP, which involves the autoimmune destruction of Schwann cell membranes. Patients may have increased CSF protein with normal CSF cell counts, a finding called albuminocytologic dissociation. Additionally, patients have slowed conduction velocity on electromyography due to demyelination, as well as nerve conduction blocks. Disease-modifying treatment of GBS involves plasmapheresis or administration of intravenous immunoglobulin. Both treatment modalities are considered equivalent and can hasten recovery by up to 50%. Supportive care is very important for patients, as up to 30% of patients develop neuromuscular respiratory failure. Additionally, patients may need cardiac and hemodynamic intensive care unit monitoring for autonomic dysregulation. So that was the main explanation in this question, but for the other questions, I'm just going to read the major takeaway. Next question. An 18-year-old girl from Southeast Asia comes to the office because of symmetric ascending weakness below her knees for the past week. She has become unable to walk over the past 3 days. Physical examination shows mild hypotension and papilledema. Upon respiratory support and administration of IV immunoglobulin and plasmapheresis, her condition resolves after 2 weeks. Which of the following is the most likely etiology of her condition? A. Acid sphingomyelinase deficiency. B. Aryl sulfatase A deficiency. C. Infection with Campylobacter jejuni. D. Infection with John Cunningham virus. E. Microsatellite instability on chromosome 4. And the answer is C. Infection with Campylobacter jejuni. I don't know what John Cunningham virus is, so I'm going to read that. Infection with John Cunningham, or JC virus, in acquired immunodeficiency syndrome or AIDS patients may cause demyelinating disorder known as progressive multifocal leukoencephalopathy. It is characterized by altered mental status, visual deficits, hemiparesis or monoparesis, and ataxia. I'm not going to forget that one. So the major takeaway here is that GBS is a potentially fatal disease characterized by rapid progressive ascending symmetrical motor weakness. It is associated with systemic infections such as Campylobacter jejuni. Okay, next question. A 20-year-old man comes to the ER because of progressive weakness for the past several days. The weakness began in his legs but has now spread to the arms. He returned from Costa Rica 2 weeks ago after visiting relatives there. He experienced a bout of diarrhea during his trip, which resolved about a week ago. Physical examination shows a marked and symmetrical decrease in strength and absent deep tendon reflexes in all 4 extremities. A lumbar puncture is performed. Which of the following leukocyte counts, glucose concentrations, and protein concentrations is most likely to be seen in the CSF analysis? This question would scare me immediately because I don't know the numbers. On osmosis, they have a lab value pull down, and you can check those out. So I'm just going to go directly to the answer, and then you can check that out. The answer is C. Leukocytes, 3 millimeters cubed, glucose 60 milligrams per deciliter, protein 800 milligrams per deciliter. So you should know that this is the levels that most likely to be seen in this case. The major takeaway here: GBS is an autoimmune peripheral demyelinating syndrome characterized by flaccid muscle weakness and loss of deep tendon reflexes. CSF studies in GBS characteristically show an isolated elevated protein count in the absence of cytologic or glucose anomalies. Again, this is called albumin-o-cytologic distinction. So how am I going to remember these numbers? Well, I can look at the lab values and look for the CSF, normal CSF values. And I can expect that this is going to be a good test question. So let's see, what if I had chosen leukocytes of 400, glucose 45, and protein 200? Why would that be wrong? It says elevated lymphocytes, normal glucose, elevated protein in CSF are suggestive of aseptic meningitis, typically caused by enterovirus. Poliovirus infection, in particular, causes destruction of the anterior motor horn of the spinal cord, resulting in muscle weakness and asymmetrically reduced muscle tone that preferentially affects proximal muscles. I'm learning a little bit here. But these numbers are still confusing. I'm going to read another one. Leukocytes 700, glucose 8, protein 500. Leukocyte dominant, elevated white blood cell count, glucose less than 10, and high protein are suggestive of tuberculous meningitis. Tuberculous meningitis is characterized initially by low-grade fever, malaise, lassitude, headache, and personality changes. Okay, how about leukocytes 2000, glucose 30, and protein 500? Neutrophil dominant, elevated leukocyte count, low glucose, and high protein are suggestive of bacterial meningitis. It comes up again. Bacterial meningitis is classically characterized by a triad of nuchal rigidity, fever, and altered mental status. Okay, let's look at the other one, the last one. Leukocytes 1000, glucose 60, protein 35. High CSF lymphocytes with normal glucose and normal protein are suggestive of lymphocytic choriomeningitis virus infections. It is characterized by influenza-like symptoms, headache, and meningismus. So how are we going to remember this is the right one? Well, we better look at the lab values and look at this question again. That is what I need to do. Okay, so let's go to the next question. A 32-year-old man comes to the office because of symmetric weakness in his lower extremities for the past week. The weakness began in the distal lower extremities, but he has noticed that it has spread above his knees over the past 3 days. He has also started to have trouble walking. He reports getting over an episode of food poisoning 2 weeks ago. Physical examination shows weakness in his lower limbs with diminished patellar and calcaneal reflexes. Which of the following structures is the most likely damaged in this patient? A. Ependymal cells. B. Lower motor neurons. C. Muscle fibers. D. Schwann cells. E. Upper and lower motor neurons. The answer is Schwann cells. Major takeaway: GBS is a peripheral neuron disease that often occurs after an infection and can be caused by immune-mediated attack on Schwann cells. Just looking at the main explanation here, see if there's anything new. They always alter it a little bit. There's always some new info in here, lots of good stuff. Campylobacter jejuni is the most common culprit of the preceding infection, while other pathogens include cytomegalovirus, Epstein-Barr virus, and HIV. Okay, we're going to go ahead to the next question. A 53-year-old man presents to the urgent care clinic. He reports difficulty with standing and walking due to muscle weakness that started a week ago. The weakness is now beginning to affect his arms. He cannot recall any inciting factors such as drug use or toxic exposure. He has otherwise been in good health apart from a minor respiratory illness several weeks ago. Analysis of the CSF shows elevated protein level with normal white blood cell count. Which of the following neurological disorders shares the most similar pathologic mechanism as the disorder likely responsible for the patient's symptoms? Is it A. Alzheimer's, B. Friedreich ataxia, C. Huntington disease, D. multiple sclerosis, or E. Parkinson's disease? Got that wrong. I said Friedreich ataxia. Why is that wrong? Friedreich ataxia, an autosomal recessive trinucleotide repeat disorder that affects the frataxin gene on chromosome 9, typically presents in childhood. Well, the degeneration of spinal cord tracts causes muscle weakness, loss of deep tendon reflexes, and decreased vibratory and proprioceptive sense. MS was the answer. That was what I thought it was, and I don't know why I didn't answer that. GBS, which often presents as symmetric ascending weakness or paralysis following respiratory or GI infection with multiple sclerosis, involving multiple central nervous system lesions disseminated in space and time, are both diseases that result from demyelination in the nervous system. Wow, just a simple answer there. Well, it's good to get it wrong because you're not going to forget it. Now, what if you had answered Huntington disease? Why is that wrong? Huntington disease is an autosomal dominant trinucleotide repeat disorder that involves neuronal death via glutamate toxicity, resulting in atrophy of the caudate nuclei. Why is it not Parkinson? Parkinson disease results from selective loss of dopaminergic neurons in the substantia nigra pars compacta, causing cogwheel rigidity, bradykinesia, shuffling gait, and resting tremor. How about Alzheimer's? This is the most common cause of dementia in the elderly, and it is a neurodegenerative disease that involves widespread cortical atrophy. While the specific mechanism is not fully understood, neuronal damage is believed to be linked to formation of amyloid plaques and neurofibrillary tangles. So there we have it. That was just a quick review of Guillain-Barre. Let's look at the basic explanation they have here for Guillain-Barre. Guillain-Barre syndrome is a rapid onset muscle weakness caused by the immune system damaging the peripheral nervous system. Many experience changes in sensation or develop pain, followed by muscle weakness beginning in the feet and hands. The symptoms develop over half a day or 2 weeks. During the acute phase, the disorder can be life-threatening, with about a quarter developing weakness of the respiratory muscles and requiring mechanical ventilation. Some are affected by changes in the function of the autonomic nervous system, which can lead to dangerous abnormalities in heart rate and blood pressure. So thanks, Osmosis, for that. Looking down, they have some great memory anchors, which I'm going to look at. This one is a patient experience, which I think I'm going to look at. That's going to be great. Anyway, thanks for checking in today. And what do we finish up with? Some Nate Dogg, I think.
Yo, what's up, Nate Dogg? Niggas just chillin' here with the homie Warren G. Reminiscing on real friendship, man. A lot of niggas don't know what that word means. Homeboys, you know what I'm saying? They just using that word. Fuck a homie. I'm looking for a friend. That's what I'm hollering. Ever since I could remember, I had friends I could depend on, clothes to lend on, money to spend on. But as time went by, my life got a little strange, and the rules in this game seem to change. Trust, honesty, and devotion, and money gets the poison potion. There's no way that I can even say that this game has been good to me, or even bad to me. It had to be, cause tragically, the way this shit cracked off a doggy dog was magically. And now I'm getting everything I'm supposed to get, but my friendship with niggas always ends up as bullshit. I listen to my mama, dog. She always try to prepare me and warn me for the drama, Lord. But how could she do what I mean, I'm do or die. But my life on the streets, that shit is suicide. So to cope, I got a dog and a low, and keep my heat close in case these jokes go for broke. I'm mashing with my clip, 2 and 3 that is. Them my homeboys ever since kids.
Hanging out with my homies, and I'm feeling just fine. I've been pondering lately, a lot of different things on my mind. It seems lately my friends list